Well, welcome to our AMCHP National Policy and Partnership Town Hall. This is our May iteration of our town hall, and I would like to welcome you all for joining us today. My name is Sherry Lou Santos, and I'm the current Chief of Policy, Government Affairs, and Communications at AMCHP. Before we begin, nothing new here for folks that have been joining us in the past, but in case this is one of your first times or you're coming back to us, just as a reminder that today's call will be recorded. All lines will be in listen-only mode, but if you have any questions for any of the presenters or panelists, feel free to type it in the chat box so that we can address it. If you would like to turn captioning on and off, feel free to go ahead and click the closed caption option in your controls bar. And we do have an evaluation survey that we do kindly ask you to fill out. We will share that survey link and QR code at the end of the call. It should take no more than 2 minutes. If you do encounter any technical difficulties, please feel free to reach out to my colleague, Gabrielle Galusha at ggalusha@amchip.org. She is also on the panelist panel here. So if you would like to chat any difficulties you might have, you can also include that in your chat. So today we'll be going over quite a bit of updates from the AMCHP team. We'll start off with the government affairs team and some of their updates, and then I'll go ahead and pass it to my colleague to talk about a perinatal substance use disorder implementation and policy hub project that we are in the middle of launching a particular phase about. We'll pass it off to our colleagues to talk about mother to baby, and then we'll close out with any question and answers. We have quite a few links that we'll be referring to during our presentation. So my colleague Gabrielle is going to drop for the entirety of attendees here the PDF of all of the links. So you can go ahead and open that document and click through the various links we're talking about as we discuss them. So I'm going to start off here with some administration updates. So for those of you that may have seen, last Friday, the president released the fiscal year 26 budget. So colloquially, this is being called a skinny budget. It's pretty overarching in terms of presenting top level requests for each federal agency. For those of you that have taken a look at the link, and if Gabrielle, you can go ahead and share that PDF to everybody that is in attendance at our town hall today, so folks can look at that budget link when they have the chance. For those that are looking at individual program level items or budget line items, those are not reflected in the president's budget as the skinny budget. Those would be reflected in what is called a congressional justification. We are still awaiting a congressional justification to be sent to Congress. So that would be when each individual agency sends Congress line item requests for individual programs. So if there's something you're looking for within the president's budget and you don't see that program listed there, don't be concerned quite yet. It's not traditional for those programs to be listed in the overarching budget. As a reminder, this president's budget is actually a proposal to provide recommendations to Congress that the administration would like to see in terms of funding levels. But at the end of the day, Congress has the authority to approve, reject, or modify the administration's budget recommendation. So there's no legal bearing to the document that was released on Friday morning. I do want to highlight some noteworthy maternal and child health inclusion. So overall, for the Department of Health and Human Services, the administration requested $93.8 billion, which reflects a 26% decrease from fiscal year 25. Specifically for the Health Resources Services Administration, so HRSA, there was a requested decrease of $1.732 billion, so billion with a B. And specifically for maternal and child health programs, there was a recommended decrease of $274 million for programs which, quote here, are duplicative of other federal programs or could be addressed through block grant funding. So there's a couple things here where we're reading between the lines that there is a perception that there are quite a bit of programs that are duplicative in nature, and that is something that AMCHP and a lot of other national advocacy organizations are continuing to work on education and awareness to ensure that Congress and the administration are aware of the complementary nature of various programs and why, let's say, for instance, there's a program I'm going to take sickle cell as an example. There is a sickle cell program within CDC and a sickle cell program within HRSA, and why those are very distinct in the nature of what they do, but complementary to one another. So really critical to maintain the various pots of funding and programs that already do exist that Congress has authorized and or appropriated funds for in the past. I also want to call attention to a rather large cut to the Centers for Disease Control and Prevention. So it was a requested cut of $3.588 billion, which reflects a 45% decrease from fiscal year 25, and some noteworthy delineations within that, within the Centers for Disease Control and Prevention, so CDC. Portion of the president's budget was the specific call to eliminate the National Center for Chronic Diseases Prevention and Health Promotion. So that is the center where traditionally the Division of Reproductive Health ran a lot of programs for the maternal and child health community and population. For example, federal support for maternal mortality review committees lived within that center. Perinatal quality collaboratives lived within that center. The PRAMS data surveillance program lived within that center, et cetera. So that is something that we are paying close attention to, and again, increasing a lot of awareness and education efforts around the importance of those programs to try to see what is really the next step, what is Congress's intent on maybe taking this recommendation from the White House into account as they put together their fiscal year 26 budget. And then a specific call to eliminate DEI programs. Our presumption is in line with the DEI or DEIA executive orders that were released earlier this year. So moving on to congressional updates, I noted that the president's budget is a recommendation to Congress. So I'm just going to back us up a little bit here with the appropriations process. And appropriations in congressional speak is a fancy term for funding the next fiscal year. So if you take a look here at the top, the appropriations process starts, or ideally should start with the White House, where the president would submit a budget request to Congress. So that's what the president's budget that I just talked about was. And traditionally, that gets sent to Congress somewhere around February. As you can see, it is already May, so we're quite delayed in this timeline, and it's not exactly linear. So if you take a look at the next step after the president would submit that budget request with, and I'm going to caveat here, it's not really included in this box, but a few weeks after the overarching president's budget, traditionally the congressional justifications come out. After that, typically the House budget committees in both chambers would develop a budget resolution, but this year we are doing things a little bit out of order. So for those of you that joined the April town hall, I talked about the budget resolution and the fact that both the House and the Senate already passed a budget resolution. So we're going a little bit out of order for the fiscal year 26 process. And then the next step would be that the House Appropriations and the Senate Appropriations subcommittees draft and pass their appropriations bills, push it to the full committees, the appropriations committees, to then pass it, and then push it to each chamber to pass those appropriations bills. If the appropriations bill gets passed in the House and the Senate, the same exact version, then it gets to the White House for the president to sign the appropriations bills into law, theoretically and hopefully by October 1st, which is the start of fiscal year 26. It's been quite a while since we've had appropriations bill passed by the start of a fiscal year. So there's some alternative approaches that do exist. One is an omnibus spending bill. So instead of 12 individual appropriations bills getting passed, so an appropriations bill for defense, the defense budget, an appropriations bill for labor, health, and human services. Like typically there's 12 different ones. The omnibus approach is putting all of those bills together into one big bill. So that's an approach that that has been taken over the past couple fiscal years. And then another approach that's been taken is a continuing resolution approach, which is what we're actually functioning in terms of funding for fiscal year 25. So that's just kind of an overarching view of the appropriations process as we continue to talk about how we're moving along with appropriations for fiscal year 26. So where is AMCHP right now in terms of prioritizing some funding requests? These numbers aren't going to be very different from what you all have seen if you guys have been following AMCHP advocacy for MCH programs over the past couple of years. So for Title V, we are still requesting $1 billion as it stands today. So $1 billion to increase the amount of both state formula funding as well as special projects of regional and national significance, or SPRANS funding, to get us to a point where we have where Title V programs have a bigger impact and footprint to be able to address the flexible needs in every single state. However, as we go through the appropriations process, cognizant of the fact that the administration is suggesting and trying to move different things in terms of reorganizing the Department of Health and Human Services, and as Congress talks about various programs and funding levels, all of these numbers, depending on how things get reorganized, may shift, right? So again, as of today, we are asking for $1 billion. We are also leading the effort to ask for increased funding for 2 CDC line items. One is the Safe Motherhood Program, which covers a lot of the things I talked about within the National Center for Chronic Disease, where federal support for maternal mortality review committees lives, perinatal quality collaboratives, et cetera. So asking for an increase of $164 million. And CDC's SETNet program, or Surveillance for Emerging Threats to Mothers and Babies, which is a data surveillance program to track how emerging threats such as syphilis or COVID-19, when that was a very looming threat, or Zika, when that was a really looming threat, how threats like that affect not only the mother, not only the baby, but the entire mother-baby dyad. So requesting $100 million for the SETNet program. And then the Healthy Start program requesting $200 million for that program. I highlighted here where so the blue column from the second to the right, that's where we landed for fiscal year 24 and theoretically for fiscal year 25 through the continuing resolution. And just so we have some precedence here, I left in what levels the House and the Senate put in their respective appropriations bills for the last iteration of the appropriations process. So at that, for fiscal year 25, the Senate included some kind of minute increases in their bill. However, the House included quite a bit of decreases that we are continuing again to increase education and awareness about the importance of these programs and how they tie into other programs. As you see here, there's only 4 programs that we are prioritizing as a lead in terms of advocacy efforts to Congress. However, as you all know, there's a lot of different programs that exist that are very helpful to the maternal and child health community. So just because you don't see it here doesn't mean we're not working on it. It just means we're not taking the lead on those advocacy efforts. We're most probably partnering with other organizations that are leading those efforts, so that we're all kind of working in tandem and not disparate from one another. So I do want to share some key upcoming dates in case you all are interested, or well, key upcoming date. So next week on May 14, there's going to be a hearing in the House Appropriations Labor HHS Subcommittee. It's going to be a hearing on the fiscal year 26 funding bill specific to the U.S. Department of Health and Human Services. That's going to be at 9:30 a.m. Eastern. If you are in the DMV region and would like to attend in person, it's going to be in the Rayburn House office building, and the Department of Health and Human Services Secretary Robert F. Kennedy will be present as a witness to that hearing. Later on in the afternoon, on the other side of the Capitol, there's going to be a hearing for within the Senate Health, Education, Labor, and Pensions Committee, or Senate Health Committee. It is also going to be on the topic of the fiscal year 26 HHS budget. And if you would like to attend in person, it's going to be in the Dirksen Senate office building, where Secretary Kennedy will also be a witness and testify at that hearing. And specifically for the Senate hearing, it's the first time within at least 2 decades that the secretary is going to testify on a presidential budget before the Senate Health Committee. I think we find ourselves in very unprecedented times. So the Senate Health Committee is following the unprecedented times and calling a hearing to provide an opportunity for the secretary to discuss the president's budget for fiscal year 26, even though the Appropriations Committee is the committee that holds the power in terms of actually doling out funding for the respective programs. But given that the Senate Health Committee has interest in those programs, because they are the authorizing committee for many of those programs, that's kind of how that connects together. So moving on, outside of appropriations, I want to talk a little bit about the budget resolution. For those that have been following along, we've been talking about the budget resolution process. So just as a recap, in early April, the Senate and the House passed mirrored amended budget resolutions, which contained reconciliation directives for many committees, but 2 committees that we are particularly interested in: the Energy and Commerce Committee, which called the budget resolution bill called for a decrease of $880 billion within that committee of jurisdiction. Of notable concern is the only way to make the math work for that is to include large decreases in to the Medicaid program. And then specific to the House Agriculture Committee, there was a call for a decrease in $230 billion. And of concern would be the Supplemental Nutrition Assistance Program, or the SNAP program, or SNAP benefits that goes out to folks and families. So that is something that we are definitely watching. If you're interested, it is projected that next, I think it's Tuesday, May 13, both the Energy and Commerce Committee and the Agriculture Committee are projected to have markups on the reconciliation portion of the bill. And then other legislative efforts, in case y'all are interested, a couple weeks ago, the Senate passed a National Home Visiting Week resolution, which, sorry, let me get to my notes here, which designates the week of April 21st through April 25th as National Home Visiting Week, and really highlights the importance of the Maternal, Infant, and Early Childhood Home Visiting Program, or MICV program, and how that program supports childhood development, strengthens family relationships, and reduces the risk of child abuse and neglect. 2 other bills that we are looking at and actively monitoring and advocating for are the Preemie Reauthorization Act and the Preventing Maternal Deaths Reauthorization Act. So as an update for the Preemie Act, the Senate reintroduced that bill very recently. The House had already reintroduced the bill for this Congress earlier this year. And as a refresh for folks, the Preemie Reauthorization Act would reauthorize critical federal research, education, and intervention activities to reduce preterm birth and infant mortality. It would also include a reauthorization of the Pregnancy Risk Assessment Monitoring System, or the PRAMS program within CDC. So given a lot of the conversations around reorganization efforts, this is something that we are trying to really continue to push forward, given the bipartisan support in Congress. And for the Preventing Maternal Deaths Reauthorization Act, this bill would reauthorize federal support for maternal mortality review committees. Again, a program that lives within the National Center for Chronic Disease. at CDC. So again, given the bipartisan support, really trying to get both of these bills passed into law to really show Congress's support of both initiatives. And then I'm including here some ongoing efforts that AMCHP has taken, both in terms of appropriations advocacy and Medicaid advocacy. I do want to highlight some organizational sign-on letters that we currently have circulating. So if you are a national, state, or academic institution that would be interested in signing on to some letters in support of the Title V program or the CDC SETNet program, I have bit.ly links there for you all to read those letters and or sign on if you're interested. I also want to share some new resource alerts, given the point that I made earlier that there is some perception of duplication of intent for some maternal and child health programs. AMCHP has created some fact sheets on some maternal and child health investments. And essentially, these fact sheets provide an overview of some of these critical federal funded programs and how they complement and not duplicate the efforts of the Title V Services Block Grant and their impact on maternal and child health populations. So if you're interested in taking a look at those are found on our website. Feel free to take a snap of the QR code or type in the bit.ly link at your leisure. It's also included in the link list that Maura sent out to everybody a little bit earlier in the call. And then I'm going to breeze through judiciary updates really quickly. So as a reminder, there's been a case that's been in the courts for quite some time. It's actually March 2020 that was brought by Braidwood Management, and it was a lawsuit in a Texas federal court around the requirement to cover some Affordable Care Act preventive services, specifically PrEP, which is a medication for HIV prevention. And they essentially stated that requiring the coverage of PrEP violates the rights of themselves as plaintiffs who have religious objections. And they indicated that, or they argued that the structure of the U.S. Preventive Services Task Force violates the Constitution's Appointments Clause. So fast forwarding a little bit, in March 2023, that district court released a ruling of a nationwide injunction on the requirement for no-cost coverage of preventive services recommended or updated by the USPSTF since March 23, 2010, which is when the Affordable Care Act was signed into law. The decision would have affected access to all screenings, counseling, some preventive medications, including PrEP, that were recommended by USPSTF, but the ruling was subsequently paused as the case made its way through the appeals process. So fast forward again, last year, the Fifth Circuit Court of Appeals released their decision that the ACA's preventive services provision was ruled as unconstitutional on the grounds that USPSTF violated the Appointments Clause. However, the Fifth Circuit Court of Appeals said that the nationwide remedy, so blocking all preventive services from the entire country, was improper, but they withheld that for the plaintiff's health plans, it did violate the Appointments Clause. So it preserved, overall, that decision preserved access to preventive care under ACA for the rest of the nation, just not within the plaintiff's health plans. In September of last year, the Biden administration appealed this decision to the Supreme Court. And last month, the Supreme Court heard oral arguments on this. So we are expecting June of this year for the SCOTUS, for the Supreme Court to rule on this case. So stay tuned for that. Just wanted to give you all an update. And one more update on a lawsuit regarding mifepristone or medication abortion. As you may know, medication abortion is very common as a way for folks in the U.S. to receive abortions. Over half of abortions in the United States are medication abortions. And since 2000, when medication or mifepristone was FDA approved, there's been high efficacy and low mortality rates. In June 2024, there was a Supreme Court ruling in a case called Alliance for Hippocratic Medicine versus FDA to preserve widespread access to mifepristone. And the ruling was that there was a unanimous decision that the plaintiffs lacked legal standing to sue the FDA on regulations for mifepristone. However, there are 3 states, so Idaho, Missouri, and Kansas, that continue attempts to roll back access to mifepristone. But as of May 6th, so 2 days ago, the Department of Justice requested dismissal of this case to drop this case against medication abortion. So wanted to keep you apprised of that. And as things continue to move through the courts, we will continue to keep you all updated. So I'm going to go ahead and pass it to my colleague Maura. And I know there's a couple Q&A, so I'll attempt to answer those as my colleague presents.
Wonderful. Thanks, Sherry Lou. And hi, everyone. It's great to be here with you all today. I'm excited to share a little bit more about a really exciting opportunity that just opened this week. That's a part of our perinatal substance use disorder implementation and policy hub project. So you can go to the next slide. So for those of you that don't know me, my name is Mara Leahy. I'm a Senior Manager of Training and Technical Assistance here at AMCHP of Child and Adolescent Health Initiatives, and I'm supported by some fabulous teammates of mine on our Evidence and Implementation team, Ollie Quo, Noelle Vasquez, and Linda Crisawati. Jess Simon is the project director for this. She's out on parental leave, but myself, Ollie, Noelle, and Linda, there's no wrong door if you just want to reach out to any of us to get a little more information, but I'm just going to do a brief project overview and tell you a little more about this specific opportunity that just opened. So on the next slide, the project itself has a couple main goals. This is a 2-year project that's funded by the Foundation for Opioid Response Efforts, or FOR, and the Perigi Fund. So really, we're trying to grow the number of perinatal substance use disorder practices in our MCH Innovations database. We're going to be hosting national trainings and learning events, doing some in-depth technical assistance for 6 organizations, and ultimately developing a national perinatal substance use disorder collaboration and policy action plan. So goals here really by disseminating, replicating, and amplifying effective perinatal substance use disorder practices. We're trying to strengthen those state and local behavioral health systems so the more families can get the high quality, non-stigmatizing perinatal substance use disorder resources and supports that they deserve. Our national trainings and convening are really going to be focusing on enhancing perinatal substance use disorder stakeholders' cross-sector collaboration and their policy capacity, again with that ultimate goal to improve outcomes for families that are impacted by perinatal substance use disorder. If you go to the next slide, I feel like many, hopefully most of you all on the call are familiar with our AMCHP Innovation Hub. It's one of our flagship resources. It's overall just this amazing online platform that has resources related to identifying and sharing, replicating evidence-based practices and policies. And one core part of the hub itself is that MCH Innovations database. And so the database is a searchable what's working in MCH. So you can search by state, setting, topic, population, national performance measure. And then there's also a practice continuum that's assessed by sort of what level of evidence you have indicating impact and other criteria that goes from cutting edge all the way up to best practice. So you can enter the database at any level, and then you can work your way up the continuum as you learn more about your impact and have other criteria, things like how you implement continuous quality improvement, how you practice collaboration best practices, or how your practice has been replicated in other settings. So on the next slide, we are very excited to announce we have 13 new practices and policies that were just added to the database. And these are really innovative practices and policies in different settings. So we have some that are clinical settings, others that are in justice settings, some that are in public health settings, and we're really hoping that we'll be able to add even more to the database early next year. And the really sort of great opportunity here is that we have an opportunity for you to replicate one of these new practices or policies. So if you go to the next slide, I mentioned earlier there's going to be some in-depth TA for 6 organizations, and that's really going to be taking the form of these perinatal substance use disorder replication projects. So what we're going to be doing is we'll support 3 organizations at a time. They are going to be 2 9-month cohorts to replicate a perinatal substance use disorder practice or policy. So our evidence and implementation team at AMCHP has a tried and tested way of facilitating these projects that includes capacity building and implementation support. As a part of the replication projects, an organization would get a $10,000 replication award. They would get peer coaching from the coach of the practice or policy that you're replicating. as well as implementation support, and really just tailored TA throughout the cohort. And so we just opened the call for applications for the first cohort on Monday, and so this cohort is going to run from June of this year until February of 2026. And so why I'm here today is to just let you know a little more about how you can apply or just share this opportunity with others who are interested. So if you go to the next slide, we have a couple different sort of resources. These are all on the links that were posted in the chat, but there's basically a couple steps that would need to happen. So if you or you know another group or organization that is interested in replicating a practice, we have a survey that you would need to fill out. We have a few other sort of complementary resources that are connected to the survey and the opportunity overall. So we've got a replication project timeline that just breaks down sort of what's going to happen. So we have sort of a tiered process where folks can apply. We'll then be inviting qualified applicants to do an interview with AMCHP. We'll be making decisions after that. We have a what to expect if accepted resource that just kind of details what if you're one of the 3 selected organizations who has chosen to replicate a policy or a practice, what that would look like over these next 9 months. There is the summary. We have a summary resource. So I shared those 13 new practices and policies. We have a summary resource that kind of just like details them all a little bit more. They're all actually in the MCH Innovations database where you can learn more about the policy or the practice. We are currently working on getting their full implementation handouts up, but in the meantime, if you are looking for more information about the practice, you can reach out to our team and we're happy to share some more detailed information about the practice or policy with you. And then there are the last two are really tied to the application itself. So if you are interested in applying, you do need to include a short letter of support from the practice or policy that you want to replicate. So we have a template for this. So if you don't already have a relationship with the practice or the policy that you're interested in replicating, we just suggest that you reach out to them to give them a heads up, say, hey, we're interested in replicating, and since they would need to be committing to be your coach throughout the experience, it's just letting us know that, okay, if you were selected, you've already met with them, you've talked with them, you as the organization, and then the coach would be ready to commit to the experience. And then we just have a replication project team table as well, and that just details a little bit about who would be on your replication project team, what are the different roles that folks would fill. And so we've got sort of just kind of this litany of resources that tells you more about the opportunity. It's going to be open until May 23rd. We may close the survey early, just depending on the number of qualified applicants that we get, since we can only select 3. However, this opportunity is going to be replicated in the spring. So we should be opening the call for the next cohort, I would say probably in January or February. So if you're not able to make this quick turnaround for the May deadline, we are going to be having another cohort as well. So that's a little bit about the opportunity. Does anyone have any questions? I'll also put my direct email address and then the evidence and implementations team's email too. And there's really no wrong way to reach us, and we're happy to share any more information, answer any questions that you might have about the opportunity.
Thanks so much, Maura. I don't see any current questions in the chat or the Q&A function. So I think maybe we'll just give some folks some time to mull over some questions, but I think we'll go ahead and pass it now to our colleague Lori to speak about mother to baby. Thanks so much.
Hi, thank you so much. I'm really happy to be here. My name is Lori Harris Sagadibai, and I am a teratogen information specialist with Mother to Baby. And by the end of my presentation, you will know what that means if you don't already. I'm a teratogen information specialist with our Mother to Baby service in North Carolina, and I'm also currently the president of our national organization. And Mother to Baby has a history of partnership with AMCHP. And today I was asked to talk with you about Mother to Baby, what we do, and how we help to support professionals working in the maternal and child health field, as well as how we help the women and families themselves. Next slide. So Mother to Baby is a free service of the nonprofit Organization of Teratology Information Specialists. And we provide evidence-based information about the risks and benefits of medications and other exposures before and during pregnancy and while breastfeeding. The service is available to anyone. That's healthcare professionals, people working in community service field, parents, families, prospective adoptive parents, anyone who has questions about specific exposures that a person may have during pregnancy, before pregnancy, during the adoption process, or while breastfeeding. And the mother to baby service is, we have trained specialists from a variety of professional backgrounds that provide this information in both English and Spanish. So our backgrounds include medical fields as well as public health, genetic counseling, a variety of fields. Regardless of our professional background, we are all trained as teratogen information specialists to be able to assess the research around different exposures and distill that information and provide it in a way that is understandable and useful to families as well as their healthcare providers. Next slide. So when we say exposures, what exactly do we mean by an exposure? So an exposure can be anything that a person might be exposed to before pregnancy, while they're trying to conceive, during their pregnancy, or while they're breastfeeding. So that could be a medication, a vaccine, could be substances, and the perinatal substance use disorder was such a nice seg into the mother to baby service. Questions about cosmetics, chemical exposures, infections, supplements, maternal medical conditions, and more. Next slide. So why do exposures matter, particularly looking at the maternal and child health population and ways that we can work to improve maternal and child health? Exposures matter because some exposures in pregnancy can increase the chance of birth defects. Some exposures in pregnancy can also increase the chance of developmental disorders, such as developmental disabilities, behavioral challenges later in life. Some can also increase the chance of pregnancy loss, miscarriage, or stillbirth. And some exposures in pregnancy can increase the chance of pregnancy complications. So things like preterm delivery, low birth weight, and other complications in pregnancy that can impact the health of the pregnant woman as well as the child. Can we hop back just a bit? Thank you. And some exposures in breastfeeding can cause adverse effects on milk production. And of course, when that happens, that can lead to an interruption in breastfeeding or early discontinuation of breastfeeding. Can also cause side effects for breastfed infants and children. So any of these outcomes can have long-term implications for a child's health and development. Next slide. In contrast, when we have accurate information, it can have a really significant impact on the health of women and infants. It can allow healthcare providers and patients to make informed decisions around patient care. It can help individuals and families consider both the risks and the benefits of potential exposures to help them make informed choices about using a medication, about using a substance, about traveling to an area where they could be exposed to a vector-borne infection, for example. Having accurate information also helps reduce the unnecessary discontinuation of needed medications, as well as the unnecessary interruption of breastfeeding. So great examples of this are in the mental health field, that often people are misinformed about the potential impacts of their mental health medications on their pregnancy or during breastfeeding. So they either go off of these medications that are really important for them, or they decide to stop breastfeeding because they need to take the medications. And not all of these medications need to be discontinued during pregnancy or breastfeeding. So making sure that people have accurate information is a way to make sure that they are making informed decisions about their medications in pregnancy and breastfeeding. Accurate information can also help prepare families for the possible effects of prenatal exposures that have already happened, whether this is in their current pregnancy or whether this is an adoptive family who knows that there have been certain prenatal exposures for a particular case that they are considering. Being prepared really helps reduce anxiety and provides peace of mind. Next slide. So just a bit of history. Dr. Kenneth Lyons Jones founded the first teratogen information service in 1979 at UCSD. And some of you who work in the FASD realm probably recognize Dr. Jones. He and David W. Smith first identified fetal alcohol syndrome in the United States in 1973. And that was really the impetus for establishing that first teratogen information service, because once it was discovered that alcohol was a teratogen, it opened up all these questions about what else could be a teratogen. And having this service was really a way of linking the research on exposures with the healthcare providers and the families who needed that information. Next bullet. So in order to connect the now growing field of teratogen information services and specialists, the Organization of Teratology Information Specialists was established in 1987. Next bullet. And Otis established a national call routing system in 2002 so that anyone in the United States could contact an affiliated teratogen information service regardless of where in the country they lived. And in 2013, Otis renamed this network of affiliated services Mother to Baby, because that is so much easier for people to manage than the Organization of Teratology Information Specialists. Next slide. And today there are 10 Mother to Baby affiliates, and collectively we serve all of the US and the US territories. So that, again, regardless of where anyone lives in the US or territories, they have access to a teratogen information specialist. Next slide. So across our decades of experience, Mother to Baby has become a trusted resource. We're suggested and supported by agencies, including the Health Resources and Services Administration, Centers for Disease Control and Prevention, and the FDA Office of Women's Health. And these are just some screen captures of some CDC web pages on medications and vaccines in pregnancy, where they do refer to Mother to Baby specifically as a resource for questions about these vaccines and medications in pregnancy. Next slide. So the way that people can contact the Mother to Baby service is by phone, text, email, or live chat. So that original call routing system that was established previously has now expanded to include texting, email, and chatting, because we do want to make it as convenient for people as possible. And we also recognize that for a lot of the younger generation of parents, the idea of picking up the phone and making a call is just not something that's very appealing to them. So offering that texting option is really appealing for a lot of people, as well as the ability to live chat with us directly on our website. The service is always free, regardless of how you reach out to us. It is confidential, so even people who have sensitive questions about exposures, they are not required to provide us with any identifying information. And we try to, again, make it as convenient as possible. Next slide. So just a little bit about some additional resources that we have, in addition to the ability to contact a Mother to Baby specialist directly. Next slide. One of our most popular resources is our fact sheets. And this is a collection of about 300 fact sheets that are available on our website. They cover all different exposures: medications, substances, infections, occupational exposures, and they're available free in English and Spanish. Some of the sheets are also available in French. These are all evidence-based sheets. They summarize the research on these exposures in pregnancy, as well as the preconception period, during breastfeeding, and a paragraph about paternal exposure to these substances as well. They're updated at least every 2 years. Some of them are updated more frequently, marijuana being one of them. And again, these are free to view, to print. They make great patient education resources, and they're very popular among healthcare providers. Next slide. A couple of our other resources include our Mother to Baby podcast series and our baby blogs. And these really take a deeper dive into some common exposures or current exposure topics. And they're often topics that either we're getting a lot of questions about at our service, or they are timely topics such as natural disasters or maybe exposure topics that are trending on social media. So the blog series and the podcast series are just ways for us to tailor this information and present it in another format. And the series often feature guests from our partner organizations or other invited experts. Next slide. One of our newer resources sort of takes the idea of a pregnancy calculator to the next level. So this is an interactive tool that allows the user to not only find their estimated due date, but also to overlay the timing of any exposures they might have had during their pregnancy to see what kinds of fetal development might have been taking place at that time. That doesn't necessarily mean that that exposure was harmful to that fetal development, but if it is an exposure of concern, it allows them to see really what was taking place in terms of fetal development at that critical time. So it's a really nice tool for healthcare providers to be able to use as well. Next slide. So we've also developed some tools in collaboration with our partners. These are available on our website as well. They include our guide to radiation sources during pregnancy that we developed with the Health Physics Society, as well as our medication and pesticide safety tips sheets that we developed in collaboration with the Arizona Poison and Drug Information Center. And the Arizona Poison and Drug Information Center is actually where our Mother to Baby service in Arizona is located. Next slide. This is a poster that some of you might have seen at the recent AMCHP conference. It was co-presented by AMCHP and Mother to Baby. And our two organizations met last year to talk about some areas where our interests align and where we might be able to work together to fill some gaps in resources. And AMCHP has an interest in heart health currently. And so together we identified rheumatic heart disease and group A strep infections, which can actually lead to rheumatic heart disease. Those infections in pregnancy as exposures that significantly impact certain maternal populations, but for which there are really limited resources available for healthcare providers and patients. So the poster describes how we work together to develop new mother to baby fact sheets on group A strep, rheumatic heart disease, and group B strep. And then a bit about our next collaborative steps, which will be to disseminate these resources to key healthcare providers and patients. Next slide. For those of you who are working in the breastfeeding realm, I want to be sure to mention the LactRx, which is an app supported by Mother to Baby that provides easy access to the National Library of Medicine's LactMed database, which some of you may be familiar with. The app, again, provides access to the updated information. There was a previous LactMed app that still exists, but it's no longer updated. So the LactRx app replaces the previous LactMed app. And this is a free app for iPhone and Android. Next slide. And I'll wrap up by just mentioning another arm of Mother to Baby, which is our Mother to Baby pregnancy studies. And these are observational research studies that are designed to gather information on exposures in pregnancy. And this research is so important because this is how we get the information that healthcare providers need in order to counsel their patients about any possible effects of their medications or their maternal health conditions on a pregnancy, as well as to make informed decisions about medical care for these patients. So you all can help with this effort by referring your patients, letting healthcare providers in your communities know about these pregnancy studies, because patients can sign up on our website to participate in these observational studies, and you can find more information about them on our website. Last slide. So this is my contact information. I'm happy to take any additional questions now. You're welcome to reach out to me later with any questions that you might have. So thank you so much.
Great. Thank you so much, Lori, for that abundance of rich information and sharing with our crew here today on today's town hall. Karina, next slide. So in closing, I just want to remind folks that our next AMCHP Policy and Partnership Town Hall will take place on Thursday, June 12th from 2 to 3 p.m. Eastern. It's very easy to remember. It's every second Thursday of the month from 2 to 3 Eastern. If you are not already registered, you can register at the bit.ly link. I seem to have a typo there that says bit.lv. That should be bit.ly at AMCHP at that link there. And again, there's a 2-minute evaluation survey for today's town hall. We would love to hear from you, both how today's town hall went and what other topics that you all might be interested in us doing a deeper dive on for future town halls. And last slide, I believe. Great, so that is all we had for today. It looks like there are no further questions in the question and answer or in the chat. So I appreciate your all's attendance and look forward to seeing you at next month's town hall. Thanks so much and have a great rest of your day and week.